the ghettos were created, not by the people who live in them, but very much so by people who didn't. And so when we have that level of institutionalized racial and class oppression, it's going to affect the behaviors, if you will, the consumption patterns, the quote-unquote lifestyles of the people who are left behind, but we cannot divorce those lifestyle choices and those decisions from that cultural context, and yet we usually do. Very rarely do we place the onus of the blame on that institutional oppression, let alone do we call it that. We're very afraid to call it that. We just sort of pick up after the ghettos have been created, and we ignore that which brought them about, which is ahistorical and irresponsible. More to the point, though, it isn't just that. It is that in some ways there are certain behavior and lifestyle choices that actually whites make that are far less healthy and yet do not translate to the same kinds of health problems in spite of that fact. So contrary to popular belief, for instance, white Americans at all ages actually have higher rates of smoking, higher rates of excess and binge drinking, and equal drug use rates with African American and Latino folks. Contrary to popular belief, contrary to mythology, contrary to the conventional wisdom of those who haven't actually looked at the research. And so here you have white folks actually engaging in a few areas equal to or greater than people of color that are detrimental to health, and yet it's not translating in spite of that to the same impact that even healthier people of color in terms of their lifestyle choices are having to experience. We also know, for instance, that when it comes to issues like infant mortality, African American women who do not smoke at all, at any point during the gestation of their soon-to-be-born child, or at any point before, who have never smoked, have higher infant mortality rates than white women who smoke not only before becoming pregnant, but all throughout their pregnancy. So it isn't just about behavior, it isn't just about lifestyle. Even when white women in this case engage in behavior and lifestyle choices that are far less healthy for their soon-to-be-born children, they are actually having healthier outcomes for those children than African American women who did everything right. So it can't be just behavioral. Then we come to the economic explanation. This is the one that is really more popular, perhaps, among nice liberal people. Nice liberal people are more than willing to say, well, the problem is poverty, and if we could just solve poverty, that's the problem, is that people of color are disproportionately poor, and so if we just got rid of poverty, that would solve the problem. Well, that's a very nice theory, and there's no question that solving poverty is a very good idea on its own terms, and solving the conditions of poverty is a very good idea on its own terms. And there's no doubt that that would have some effect on the racial gaps that exist between white and black or white and brown. But the evidence is overwhelmingly clear, though rarely ever spoken in this country in the media or by any of our politicians. The evidence is overwhelmingly clear that it would not be anywhere near sufficient to closing the racial health gaps, because some of the biggest gaps between white and black health, for instance, manifest at the top of the income range, not between the top and the bottom, but at the top, between white and black folks, for instance, who have good jobs, who have health insurance, who have decent occupational status, and yet have very different health outcomes, particularly in the area of blood pressure, for example, and stroke, hypertension, etc. We know, for instance, from the research, and I fully footnote all of this in my book, Colorblind, which if I had them, I would totally sell you merchandise, but I don't have any, so you'll have to get those on your own. The data, for instance, demonstrates that black women, we'll look again at infant mortality as one of the main ways in which we determine these racial health gaps and look at them. Black women with a college degree have higher rates of infant mortality for their newborns than white women who dropped out before they even went to high school. Dropped out maybe at the age of 16 when they were first able to drop out, maybe hadn't even started high school yet, or maybe had started, but certainly no more than maybe 2 years of high school. So African American women who went to college, got a degree, and almost by definition are going to have better occupational status than those white women who dropped out before graduating high school. They're almost by definition going to earn more. They're certainly more likely to have access to primary preventive health care than those lower income, lower occupational status, and lower education white women, but they're having worse outcomes than the women who had less economic status than they. Black women who have a degree compared to white women who have a degree, so same level of educational opportunity and access, those African American women right now 3 times the infant mortality rate of comparable white women with the same education. So it can't just be about class status, educational attainment being one of the 3 main determiners of socioeconomic status that sociologists typically look at. We also know that African American women have higher infant mortality rates for their offspring than white women, even when those black women earn 3.5 times more income per year. So a black woman with 3.5 times more income than a comparable white woman still has higher infant mortality rates than the white woman who's earning less than a third of what the African American woman is earning. Black women who had early prenatal care and prenatal care all throughout the course of their pregnancy, twice the infant mortality rate of white women who had late or no prenatal care. Once again, cannot merely be about class. It cannot simply be about access to health care. It cannot just be about affordability, as important as that is, because here you have a situation where women who have health care, who are able to obtain health care early and often and throughout the course of their pregnancy, still having worse outcomes for their newborns than white women who did not have that kind of health care. Interestingly, we find in this research that white women who started out poor, but maybe over time became upwardly mobile, got a better job, got an education, maybe they started poor, but by the time they're adults, they've worked their way into the lower middle class or whatever, maybe even the solidly middle class. That white women who start poor but see their economic conditions improve, see their health outcomes improve for themselves and for their offspring in terms of infant mortality rates, low birth weight, et cetera. But African American women who start poor and see their economic condition improve, see no marked increase in their own health outcomes or the outcomes of their offspring, none whatsoever. And interestingly, foreign-born black folks, right, when they come to this country, particularly African American or African descended women, right, when they come from the continent of Africa as immigrants, when they come from the Caribbean, when they come, in fact, from any majority black nation, they actually come to the United States and they have health outcomes for they and their offspring that are roughly comparable to that of white folks here. Right? It is only after one generation, right, only after one generation, however, those offspring of that first immigrant group begins to have health outcomes comparable to African Americans, not to white. So they come with health status that is roughly equal to that of white folks. And after just one generation, what's that, 25 years roughly? Their offspring are having health outcomes that are comparably bad to African American folks who have been in the country for generations. So something is happening. It's not about genetics. Can't be that just proves it can't be African genetics, because African women are coming. If it was African genes, folks straight from Africa right now, that's what they got. Like that's their genetic makeup. If there was something messed up about African genes, those women would be the most messed up. Those folks coming from Africa would be the least healthy. But in fact, when they come, they're healthy. You see, so it can't be genetics. Can't be culture in some apolitical, ahistoric vacuum, and it can't be economics in a vacuum, because even when folks of color are better off on a whole list of factors than their white counterparts, they're still having worse outcomes. So what's happening? And why is it we don't talk about it? Because there's really only one thing left. And it's the one thing we can't speak of. It's like Voldemort in the Harry Potter stories. Right? Or it's like Fight Club in the movie Fight Club, right? It's the first rule of Fight Club is we don't talk about Fight Club, right? And Voldemort is he who cannot be named. Well, in this particular instance, that's what we have. The only possible remaining explanation is about racism itself in one or another manifestation, not as an outgrowth of classism, not as an outgrowth of economic injustice, but as a unique contributor to those outcomes. And it's the one thing that never, ever gets mentioned by either this administration or anyone else in Congress or anyone at all in either political party, because of a persistent fear, I suppose, that to bring this up will be to invite criticism that one is playing the race card. They do that anyway, right? The president never talks about racism, and yet when the healthcare reform proposal was floated, which, for me and I think for maybe many of us was a pretty mild reform, albeit, preferable to what we have, but a mild reform. Glenn Beck, in his infinite wisdom, that was a joke. Went on television and said, in the midst of this discussion, you want to know what the healthcare debate is really about? And I was so sucked in. I was like, I'm a total sucker for this guy. He's just like such an entertainer. Because first, actually, he started off, he said, friends, and I was like, really? Wow. Are we friends, Glenn? I was hypnotized. It was crazy. And he said, you want to know what the healthcare debate is? And I did. I wanted to know. I really wanted to know. And I thought I knew. Like, if you had asked me, I would have put $100 on, healthcare, because that would just be me. I thought that was what it was about. But that's because I'm an idiot and do not possess the superior wisdom of Glenn Beck, who then looked me right in the eye, because he's just talking to me. He wasn't talking to anybody else. He said, it's not about healthcare. And I went, oh my God, how did you read my mind. Oh my God, how did you do that? I said, what is it about, Glenn? And he told me, just like we were having a conversation. He said, He said, well, it's really just about this administration trying to settle old racial scores. It gets better. It's about this president trying to get reparations for slavery. Yeah, I didn't see that coming either. Yeah, that was heavy. And see, I made the mistake in that moment. Don't ever do this. This is a piece of life advice. I'm just going to, this is free. Don't ever make the mistake of trying to climb into the head of someone who says something like this, one of these talk radio guys, and see what they see, because it's a scary place. It's not a place to which you need to visit, not even for a second. I tried, though. Instead of just realizing it for what it was, which was this ridiculous dog whistle to his base of people, right? Way to push a button of white resentment, right? And say, they're coming for your money and they're going to give it to those people. I mean, that's a 45-year tactic, right? It's nothing new. I shouldn't have been surprised by it, but it still sort of knocked me off guard. Because I tried to figure out, like, really, reparations? Like, what kind of reparations is it that you got to get sick to get paid? What kind of scam is that? Like, did some evil genius black person come up with that? Were they like sitting in their house one day and they were like, man, I got to figure out how to get this 40 acres and a damn mule. I've been working on this for a really long time and we just can't seem to convince anyone. I got to come up with a plan. Oh my God, I've got it. And then this evil genius black person gets on the phone and calls up all the other black people, because there's an app for that. And let me clear this up for the white folks. There's not really. I always have to clear that up, because I know how we are. Like, if we hear that there's an app for that, we're going to be like, that's racist. If there was a white people app, they would call that racist. That's racist. So anyway, so the evil genius calls up all the other black folks and says, hey, I've come up with the plan for reparations. You want to hear it? And all 35 million black folks, and don't act like some of you weren't on this call, all said, well, we want to hear it. And he says, okay, check it out. Check it out. Here it is. Cancer. No, that's not a plan. That's not a plan for reparations at all. That's not brilliant. It's not a good idea. But to Glenn Beck, that argument made perfect sense. So what I'm not just telling you this for the cheap laugh, though I much appreciate the cheap laugh. I'm telling you this because it demonstrates how even when we don't talk about race, we can ignore it and think that we're somehow sliding by not talking about it, and we're going to get really good reform by avoiding that difficult topic, and if we bring it up, they might try to defeat the reform, because, they didn't try to defeat it as it was. They're not trying to undo it now, are they? Well, actually they are, and so we didn't talk about it, and they're still doing that. We didn't talk about it, and they're still race-baiting the policy. We didn't talk about it, and they're still race-baiting the president who pushed for the policy. So at some point, we really have to ask ourselves about the strategic wisdom of avoiding a race conversation just to sort of mollify the other side when they are not capable of being placated around these issues, and when they have every intention of race-baiting anything that is done to help the have-nots or have-lessers in this country, because the have-nots and the have-lessers have, for 45 years, been constructed in the political imagination of this country as black and brown. And after 4.5 decades of constructing the have-nots and the have-lessers mentally in our mind's eye as black and brown folks, anything we try to do in this country that seeks to improve the lot of the have-nots and the have-lessers will be seen by those who have been sucked into that narrative as reparations, whether we talk about race or whether we don't. So we might as well talk about it. Which then brings us to the things that we do not name. There are two things, according to the research, and it is a massive amount of research now, going back 15 or 20 years, suggesting there are two things happening that can help explain these racial disparities beyond class status, beyond so-called cultural or behavioral status, and certainly beyond genetics. The first, it's one that we really don't like to confront, and I understand why, no one likes to confront it, but is a reality, according to the research, that there is indeed disparate care being administered to peoples of color by physicians and by healthcare providers. Now, this is not because these physicians and healthcare providers are bad people. It is not because they are racist in the traditional sense of the term. It is not because they are going into their office every day trying to conspire to figure out how to provide bad care to their patients. Most doctors, like most professionals in any field, want to do a good job, and they want to do a good job by everyone, every one of their patients or their clients or their customers, whatever business or field they happen to be in. But just because you have the best of intentions to do that doesn't change the fact that, according to the research, doctors and nurses and others within the healthcare delivery system now, accountants and everybody else that have been brought into this process, right, have the same implicit and subtle and sometimes subconscious biases that anyone else has. And the evidence on that is overwhelming, that the vast majority of us, perhaps all, but certainly the vast majority of us, have some form of internalized bias against peoples of color in this country, just as we do with religious minorities, just as we do with people with disabilities, just as we do with sexual minorities, right? You can take these implicit association tests that Harvard's website and Princeton's website, I believe, has them as well, where you can actually check for subtle and subconscious bias, not the kind that's overt, not the kind that manifests blatantly in a doctor's office or a classroom or anywhere else, but the kind that can be demonstrated just below the surface, the kind that is capable precisely because it is implicit, precisely because it is subconscious, of affecting our behavior without our knowing it, and therefore without us having the ability to interrupt that process. You see, you can't interrupt a process you don't see, and if you don't see it, we must have that conversation. Several studies have found, for instance, that African Americans are far less likely to receive a variety of life-saving medical interventions, even when they have the same socioeconomic characteristics, the same health care coverage, the very same level of education, same age, same income, all of those factors which we know can affect and sometimes will affect the quality of the delivery of health care, even when all of those are held constant. African Americans, particularly black women seeking, who are manifesting certain heart conditions, far less likely, about 60% less likely to be referred for angioplasty, for example, not because they are saying, don't do this to me, not because they're intervening and saying, no, I don't want that thing that might save my life, don't do that, but because the doctors are, for whatever reason, and it really doesn't matter what the reason is, it only matters that it happens, for whatever reason are determining that the procedure that they would recommend in that very same situation, were the patient white, they will not recommend and will not pursue when the patient is of color. Whether that is because of overt bias or subtle bias, it really doesn't matter to the woman who's not getting the angioplasty. It really doesn't matter whether it is deliberate. The only thing that matters is the outcome. A study by the Kaiser Family Foundation, the American College of Cardiology Foundation, examined 81 different studies which have looked to see if there is a disparate and inferior quality level of care dispensed to African Americans, particularly when it comes to heart conditions. And of the 81 studies that have looked at that subject, 70 of them, that is to say the overwhelming majority of them, have found in the affirmative. The University of Washington, there was a big study which looked at communication styles between doctors and patients, looked at the extent to which doctors coordinated their care regimen very carefully with their patients, really talked to them and walked them through the process in a particular way. Granted, it's somewhat qualitative, it's hard to quantify all of those things objectively, but what the study found was that there is a substantial difference in the way that doctors, particularly white physicians and nurses, coordinate their care, speak to their patients, communicate with their patients when those patients are of color, not only black, but in the case of this particular study, Asian Pacific Islanders in particular, received a most definitely a lower standard of care. And then there was a study done as well a couple years after that of 2,500 physicians across the country, done from 2004 to 2006, which was an implicit bias study of physicians to determine the extent to which implicit bias manifested on the part of doctors vis-a-vis their patients. And what it found was that there was no difference between the level of implicit bias held by physicians and the general public, which is to say that about 3/4 to 80, maybe as much as 85% of white physicians, Latino physicians, and Asian American physicians manifested implicit bias toward black patients. So it wasn't just white doctors who did this. It was also Latino and Asian doctors. And interestingly, that there was no evidence of implicit bias against people of color on the part of African American physicians.